during my time as an obstetric obstetric resident, when I went to France, I was actually shocked that there is a fetal medicine practice because I'd never heard of it. We always heard that of fetal maternal medicine, but I did not come to realize that the practice of fetal medicine is so broad and so deep. So indeed, it is a new field which still needs people to understand what is it that these fetal medicine people do. So this is the focus of my talk today, to try and explain in very simple terms, because this is a refresher course which is covering from the level of midwife, radiographer, sonographer, obstetrician, and other doctors who are interested in knowing about fetal medicine. So I'm going to make it very basic and very simple. So in fetal medicine, we look at the baby and mother's well-being. This is the simplest way I can say it. In other words, we are the baby doctors or the fetal doctors. You will agree with me that as much as obstetrics has been doing a lot in terms of delivering women, there's been scanty or very little focus on fetal health. But fetal medicine comes and zeroes in on fetal health and deeply focus on the fetal health to make sure we look after the baby. So what are the services that are offered in the fetal medicine unit? The fetal medicine unit offers screening services for the following. Besides the routine obstetric screening tests that are done in most antenatal clinics, fetal medicine now screens for preeclampsia from as early as 11 to 14 weeks. And we also screen for preterm birth, history-based 11 to 14 weeks, and ultrasound scan based at the Anomaly Scan. We also screen for aneuploidy. Aneuploidy, this covers Down syndrome, Edwards syndrome, and Fetal syndrome. These are routine screening tests which are done in the fetal medicine unit. Then we also screen for fetal structural abnormalities and fetal cardiac abnormalities. We screen for more, but I've put a highlight of the commonest condition that we normally screen in terms of the screening services found in a fetal medicine unit. We screen for maternal complications, from the complications of diabetes, complications of chronic hypertension, to the complications of other medical disorders in pregnancy. And we screen for fetal conditions, we do the diagnosis of fetal conditions, and we offer treatment for fetal conditions in some cases. And we do offer the counseling services and also some preventive strategies for maternal and fetal conditions. To just zero in a little bit on the screening, which takes place between the 11 to 13 weeks, we do a first trimester scan, which is done between 11 to 14 weeks. And the purpose of this scan is to date the pregnancy and to screen women for aneuploidy, that is Down syndrome, Fetal, and Edwards, and also preeclampsia. We also do an early anomaly scan where we check for major fetal defects, that is at the 11 to 14 weeks. This scan requires extensive training and acquisition of competence to be able to do it properly. You don't just wake up and say, I can do 11 to 13 week scan. You have to undergo extensive training, and you have to be certified to say you are competent enough to be able to do the 11 to 13 plus 6 week scan. We also check the number of placentas in twin pregnancy. The question is, why is it important to have this scan? I think it cannot be emphasized enough. This scan allows dating of the pregnancy, which is a very important step in caring for any pregnancy. A wrongly dated pregnancy can't be given the right care. No matter who is looking after that pregnancy, if the pregnancy is not properly dated, there's no way you can deliver optimal care to an undated pregnancy. This scan also allows us to do risk assessment of both the mother and the fetus. I've already highlighted the period when it should be done. It's 11 to 13 weeks plus 6 days. That's when it should be done. We are advocating for this scan because it's only 16% of our women in this country who book before 16 weeks. It should be 26% of the women in Zimbabwe who book before 16 weeks. And very few percentage of those 26% actually go for a first trimester scan. Even if these patients are seen by their obstetrician or seen by midwives or their GPs, they are rarely referred to a scan at the right time to be done the right things. So we want to change this because this is wrong. This is archaic to allow women to miss a very important period in their pregnancy risk assessment. The question is, they've always been asked, because you always see either doctors or midwives who come to see us, you offer them screening for Down syndrome. I will disappoint you to say most of the health workers actually refuse aneuploid screening. Non-health workers have a better uptake of aneuploid screening than doctors, including doctors' wives, by the way. The uptake is just poor. The question is, what is it, the aneuploidy? We said aneuploidy is a condition which affects the number of chromosomes in a baby, so that the baby will have an extra number of chromosomes. And how does it affect the baby? Whenever there is an abnormality or an excess in the number of chromosomes, there is bound to be physical and mental handicap on the baby. The question, why should the woman know? Because I see most women, especially the doctors and so forth, they say, why should I know? I don't want to know. The reason for knowing is so that you can make an informed decision about your pregnancy. If we know that you are carrying a baby with trisomy 18 and 13, you know that the survival rate, if they don't die in uterus and they are born, of which less than 20% of them are actually born alive, if they are born, then you can be rest assured that the 1 year survival rate is probably less than 5%. And the 5 year survival rate is even less. So you can prepare yourself for this kind of situation if you are not the person who wants to terminate the pregnancy. But some couple may choose and say, look, I don't want to go through this pain. Why can't we just terminate the pregnancy before even 20 weeks? So in other words, you are saying a woman should have a reproductive choice in terms of knowing what they are carrying. How common are these conditions? People always ask. Some people think this is a thing for the white people. It's not there in black people. But it varies in terms of the incidence. It's between 1 in 500 to 1 in 1,000 pregnancies. Zimbabwe delivers about 400,000 women a year. That means we can potentially at least have, at most have probably 1 in 400, or we can have 400 downs amongst in a year. It is possible. How is it done? The screening is done by measuring the fluid behind the baby's neck. Then after taking the fluid behind the baby's neck, we also check the baby's nasal bone. And we can add other things like checking blood flow across the baby's heart and also checking blood flow across the baby's liver. That is the tricuspid regurgitation and also the ductus venosus. After doing that, if we then request that the mother goes to the lab to have a blood test so that we can combine the results of the scan and the results of the blood test to give the woman the risk. We are using 1 in 100 as a cutoff for high risk or low risk. We are not using intermediate risk. So if the fluid behind the baby's neck and the blood results and the nasal bone and the ductus venosus and tricuspid regurgitation come back and say the risk is 1 in 80, that means it's a high risk. And in that case, we need to offer the woman further tests, which I'll explain. When is it done? The best time is between 11 to 14 weeks of pregnancy. And the detection rate is much better, but it gets less if we were to do maternal blood only after 14 weeks. But it can be done up to around 23 weeks. Most labs will not accept your sample if you send the triple or the quadruple test after 23 weeks. So you can do the quadruple or the triple test after 20 weeks, which are just maternal bloods. What does a high risk result mean? The high risk result is just a probability. So if we say your risk is 1 in 70, What we are saying is if we take 70 women, just like that women we've just taken the blood from, only one of the babies will have doubts. The other 69 will be okay. So risk perception is always individualized. Some women will come with a risk of 1 in 70, and they will tell you, Dr. Verenga, I'm a risk taker. 1 in 70 is good enough for me. I think I'm a risk taker. I don't think it is my baby who is amongst the 1 in 70, and they will refuse further tests. But other women will say, look, doc, 1 in 70 is too high for me. I won't sleep peacefully at night. Can we do the further tests? And what are the further tests that we can do? If the woman is concerned, after we have counseled them concerning the risk that they have, if it is a high risk, then we can offer them fetal cell-free DNA test as a contingent test. It is not a diagnostic test. It is a screening test with a better detection rate that will discount some of the false positives that will come from the combined tests. Because the detection rate of fetal cell-free DNA test is so high, so we can use it as a contingent after getting a high risk result from the combined test. How good is how is it done? Fetal cell-free DNA, we now know that there are small pieces of free fetal DNA that circulate within the mother's blood from 10 weeks. And there are laboratory processes that are able to make a comparison between the baby's DNA and the mother's DNA and calculate the probability of having Down syndrome using those pieces of DNA. So this is how the fetal cell-free DNA test work. It is still a screening test, not a diagnostic test. What does this mean? It therefore means that you cannot make a decision like termination of the pregnancy based on a fetal cell-free DNA test alone. Then the other option we give to women is to go for the jugular. What is the jugular? It is doing the needle test, which is, in our case, we are doing amniocentesis because our laboratory, which we are using, is not handling the CVS sample, the chorionic villus sampling. But there is room to do chorionic villus sampling before 15 weeks if the result is high and the woman has chosen to go the jugular way. Or if the fetal cell-free DNA test comes back as high risk. The option we offer women is to do amniocentesis. So what is amniocentesis? We take the fluids around the baby and we send it to the laboratory and they run a karyotype test. Nowadays, there is an option for running a chromosome array where it is a zooming in of the chromosomes and looking for deletions and duplications, which cannot be picked using the conventional karyotype because of the low resolution of the conventional karyotype. There is even room to now do whole exome sequencing. The exome, what is the exome? The exome is the coding region of the DNA, which makes up about 2% of the human DNA. So it is now possible to zero down on the baby's DNA to look for small abnormalities to explain the abnormal result. So this is what we do in a high-risk situation. Oops. Why am I slides are not moving? Then the next condition which I will briefly talk about is preeclampsia. We are aware that preeclampsia is one of the commonest diseases in our wards, especially here in Zimbabwe. So it is now possible to screen for preeclampsia, which is high blood pressure in pregnancy, which we define as a condition that occurs after 20 weeks. In this condition, it's a multi-system disease which may affect the woman's eyes, brain, kidneys, and liver, and it goes on to affect the baby's placenta, the placenta. It is a harmful condition to both the mother and the baby. Can it be screened for? Yes, we can screen for it by measuring the blood flow from the mother to the uterus, uterinatal Dopplers. Once we have done that, we can also collect the blood and look either for papae or S-FLT1 or placenta growth factor. Currently, we are not able to do S-FLT1, we're not able to do placenta growth factor, but we are able to do papae when we do the Down syndrome screening. So it is with these results of the papae that we can calculate. The other parameters we need to calculate is the mean arterial pressure and the maternal history. We are able to screen for preeclampsia without having to do the blood test because most of our women don't afford. So we are screening for preeclampsia using maternal history, mean arterial pressure after doing blood pressure twice in each arm, and also using mean uterine arterial pulsatility index, we are able to calculate the first trimester risk for women. If it is greater than 1 in 100, we are classifying that as a high risk. So when you are doing first trimester scan, the risk for preeclampsia should always be checked when you put information in the blue application. The blue application is the Fetal Medicine Foundation application, which we are using, which we have obtained because of our license. We have to screen for both aneuploidy and preeclampsia. How should I do? What should I do if I am high risk? Because women will ask you and say, okay, so what should I do? So women who are high risk are prescribed aspirin, which they will take up to 36 weeks. And aspirin has been shown to reduce the incidence of early onset preeclampsia by about 70% from the aspirin trial. So aspirin does work in women with a high risk of preeclampsia. So this is why we have to screen it 11 to 14 weeks. And the aspirin I'm talking of is the 150 milligrams, not the 75 milligrams. So please take note of that it has to be 150 milligrams, not the 75 milligrams, and should be started before 12 weeks if possible. When can it be done? It should be done between 11 to 14 weeks, and so that the right interventions can be given between 11 to 14 weeks. Can it be done later? Yes, it can be done later. For those women who somehow miss 11 to 14 weeks, we can screen them between 20 to 23 weeks by doing uterine artery Dopplers and then calculating the mean uterine artery PI, and we can give them the risk. The only issue of doing it between 20 to 23 weeks is that we are not going to be able to give aspirin. Of course, in our setup, we can give calcium, but aspirin is not going to be of any benefit after 14 weeks. To continue giving these women aspirin, the benefit is less. So yeah, so this is why we encourage that women come between 11 to 14 weeks. Then anomaly scan. What is it? It is a scan performed. It is a scan performed by a specialist doctor to look in detail at the baby structure to rule out abnormalities. Why is it important? Again, because fetal defects are as common as 1 in 200 to almost 1% in a pregnant population, in the general population. This allows women to make an informed decision about their pregnancy. If the baby has a defect that will need intervention after delivery, the couple needs to start gathering the finances to do that. For example, sometimes we see defects we know they cannot be diagnosed or they cannot be treated in Zimbabwe. Some couples have to fly in to deliver in India so that the right operation can be done for certain babies. So it again allows women to make a reproductive choice, an informed choice. There is no woman who should be told at birth that your baby has got holoprosencephaly or any other adverse fetal condition. It is not fair to do that in 2021. So any woman's baby should be thoroughly checked by properly trained people who know how to check babies so that they can be reassured that your baby is as good as a baby should be at the 20-22 weeks scan. When is the best time? It's 20 to 23 weeks. You may read your books, and the books may tell you can do it from 18 to 23 weeks. The reason why we have advocated for 20 to 23 weeks is because we want to improve the completion rate. What do I mean by the completion rate? If the babies come at 18 weeks, with the most of the scans that are available in our country, most of the scans are available in our country are entry-level scans. They are not the right type to do a proper anomaly scan, to be honest. So because of the low level or entry-level scans available, surely people are going to struggle to see the heart at 18 weeks, and they are going to struggle probably to see even the kidneys at 18 weeks. So because of this, we do recommend that babies should be scanned between 20 to 23 weeks so that we increase the completion rate, so that people don't say the baby is normal when they know that They couldn't see certain structures properly because of the poor resolution of the machines when they were looking at a smaller baby. But when the baby is a little bit bigger, let's say around 21, 22 weeks, most babies can be seen, their structures even with an entry-level machine. So this is where we recommend between 20 to 23 weeks instead of 18, 19 weeks. When can it be done? But with a good machine, such as available in our units, we can do an anomaly scan from as early as 18 weeks because the machines have a good resolution. When can it be done? The best time is between 20 to 23 weeks, I've already mentioned. So that's an anomaly scan. And the purpose of the anomaly scan, I've already highlighted to pick up major defects. This will be emphasized when you do the fetal defects. Growth disorder diagnosis. Because of the high incidence of hypertensive disease in pregnancy, locally we have a lot of fetal growth disorders, abnormalities, most of a small gestational age or fetal growth restriction. So one of the roles of the fetal medicine is to try and assess babies' growth and see those babies who are not growing well and put them under surveillance. So we are using 10th centile as our cutoff for small gestational age baby, and the 90th centile is our cutoff for large gestational age baby. Others may ask and say, why are you not using the 5%? Why are you not using the 3%? The reason, if we use the 5%, in what we may define as a high-risk population, we may miss some babies who are otherwise not well, who are around 8%. So we are using 10% because we don't want to miss anyone. Of course, we may increase the false positive rate by picking up the small, the constitutionally small baby and putting them under surveillance. But we think by using the 10th centile, after we have collected enough data, we are going to analyze this data. And based from this data, we are going to probably decide and say what is the best centile for us to use besides the internationally publicized 10th centile to look at this baby, to screen for babies within the Zimbabwean high-risk population, which we see at our 2 hospitals. So we're using the 10th centile because we do not want to miss anyone. But at the same time, I know we may pick up babies who are not necessarily, who should not necessarily be put under surveillance. And whenever we pick small babies, we try to categorize them into either early onset or late onset fetal growth restriction. And we are using the 32-week marker as published in most of the literature. Some of them are mentioned down there. So we are using 32 weeks to say early onset and late onset. This has a lot of connotations, as one of my colleagues will highlight to you during the fetal growth protocols. Then, of course, we monitor the growth of these babies, and we always try to find the cause and say, why are babies small? But we know that the majority of the small babies are due to placenta insufficiency in about 65% of cases. Then the others could be due to either fetal infection or chromosome abnormalities, about 15%, and 20% of them are normally small. We haven't analyzed our data using this yet, but we'll probably have this information by next year so that we can share with you our own data in terms of what is normal small and what percentage is normal small, what percentage is abnormal small and is starving small due to placenta insufficiency. We also do fetal surveillance and delivery optimization. Babies who are not well, whether they are not well because they are not being fed well by the placenta, or babies who are not well because they have a defect, fetal defect, or babies who are not well because they have a fetal anemia, or they have a twin complication, or they have PPROM, or they have an abnormal placenta. We put all these babies under surveillance, where we'll be monitoring growth and also checking fetal Dopplers and assessing the amniotic fluid. That is another role of fetal medicine. Then we do preterm birth screening. For preterm birth, we look at, we are saying babies should not be born before 37 weeks, because if they are born before 37 weeks, this will increase their risk of either being admitted in a nursery or even risk of dying. So what do we do? So for women who come for the anomaly scan between 20 to 22 weeks, we offer them cervical length assessment, looking for a cervix of less than 25 millimeters, which is known to increase the risk of preterm birth. So women with a cervix of less than 25 millimeters, we put them on progesterone 200 microgram per vagina, which has been shown to reduce preterm birth by about 50%. It has other benefits, which is beyond probably this cost. Then the other service we offer is fetal echocardiography. This is a specialized scan of the baby's heart, which requires high level training to be able to do it. And who needs a baby scan, heart scan, a fetal echocardiography? These are the reasons for referring somebody for fetal echocardiography. If a fetal heart abnormality is detected at the routine scan, they should have a fetal echocardiography. Or a woman who has a first trimester scan and there is an abnormality in one of these, if the nuchal translucence is abnormal or above the 95th centile, which is 3.5 millimeters, the 99th centile, which is about 3.5 millimeters, they should be referred for fetal echo. Women with tricuspid regurgitation or women with reversed ductus venosus in the baby's liver, or women who have a first degree relative with a heart condition. The first degree relative I'm talking of here is the first degree relative to the baby, not to the mother. The first degree relative to the baby are the mother who is carrying the baby and the father of the baby and the other siblings at home. It stops there. Any other person does not change the background risk for a cardiac defect for the baby. If the woman's sister has a heart condition, that does not change the baby's background risk. It is still the same as the general population. This should be clear because we have seen women who are being referred to us because she has told the doctor that her sister was born with a heart condition. That is not an indication for fetal echocardiography. Then women who have diabetes and are on insulin, and women with epilepsy on medication, and women with lupus and are positive for anti-Ro and anti-La antibodies, and women, this I've already mentioned in other family history there, and then women who are having twins with twin-to-twin transfusion syndrome. Then when we look at the fetal sexing, we know that most women want to know what the sex their babies have. We look for sex because we know that DSDs, disorders of sexual development, are there. So we look at sex as part of anomaly, but women want to know for their preparation. So we always tell women that we'll give them an educated guess between 11 to 13 weeks. We don't write it because we tell them that's an educated guess. We are looking at our performance for this test because the literature quotes it at around 70% detection rate, but we are doing better than that. I think from the results we have so far, we'll share with you in another meeting. Then, so the fetal sex, the best time to determine is 16 weeks. These are the diagnostic services we offer. I've already told you we offer invasive testing for chorionic villus assembly. We are not doing it because there's no lab which is able to handle our samples, but we are doing amniocentesis. We are doing fetal abnormality diagnosis. We are doing fetal heart defect diagnosis. We are also offering intrauterine procedures. Currently, we are offering amnio reduction, fetocide. These are the procedures we are offering. We have not come across a case we have to do intrauterine transfusion, but it's something we have to explain in the future. And we have not come across a case we have to give intrauterine medication, but it's something that we are going to explore in the future. Right, so I've already explained this. How we work in a multidisciplinary platform. We work closely with the obstetric teams who are the primary doctors of the patients. Then we involve neonatologists when there is need, and pediatric surgeon, pediatric neurosurgeon, pediatric urologist, and pediatric cardiologist and cardiothoracic surgeon in the management of the cases that involve any of the above discipline. Then we also offer fetal medicine counseling, perinatal loss counseling, and preconception counseling. And who needs it? If somebody comes to us and tells us that they have intrauterine fetal demise, we have to counsel them, we have to investigate. Even if a baby is dead, we still have to scan the baby and try to find possible pointers as to the cause of death. Every woman who loses a baby, for them to get a closure, they want to know why exactly their baby died. Then we do fetal abnormalities, cancel those with fetal abnormalities, then those with fetal growth restriction with abnormal Dopplers. Then we also cancel those with monochronic pregnancy and other higher order multiple pregnancies. We cancel them concerning the risks that the pregnancies carry, so that they are fully informed and they are aware of the kind of care they need. Then we also do recurrent pregnancy loss counseling. Women who come to us with recurrent pregnancy loss, we see them and we try to assist them. But we hope that the other specialties will take over this recurrent pregnancy loss, because ideally it should be done by people from IVF, not by us, recurrent pregnancy loss clinics. Then communication. One of the weakest point in our training in Zimbabwe at the moment, whether it be training at the medical school, training at the midwifery school, or training at the sonography or radiography school, it is communication. Our communication skills are not being properly sort of done, so that we are very bad communicators. But one of the things that we have emphasized in the fetal medicine is to try and reinforce communication, to say whenever you are expressing yourself, mind how you express yourself to the patient, both verbal and non-verbal communication. And a modern doctor should show empathy, and a modern doctor should be able to decode the Latin language, which is in books, which we were taught and we examined on, and simplify it to the level of the men in the street, men and women in the street, so that they can understand you. Fetal medicine is special in the fact that in most cases, the patient is not the woman. Our patient is what the woman carries. And what we are trying to do is we are trying to explain to the patient's relative what is bothering their relative. So we really need to be good communicators, to mind how we speak to people, and to watch our words. We don't just rapture from nowhere. For example, you are scanning someone who comes to you joyfully and says, "Sister, I'm very happy, my baby, I was told I have a baby boy in the previous scan, I'm very happy, I've come for a scan again." Then when you put on your probe, you discover that the baby unfortunately is demised from one reason or another. There's no need for you to just say, "Mzukuru mwana wako afa, the baby is dead." Do you hear that? This is not how we speak, even as Africans. It's even an African to speak that way. We need to find a way of breaking the bad news, and we need to package it in a good way. Why do we have to do that? Pregnant women are women in a bubble. They are so expectant, and they've already created an image in their head, and they've built a new world for themselves. This is why you see when women are pregnant, they have the confidence of even flying to Dubai to go and buy preparation for a baby who has not come out. Because they have already envisioned the whole scenario. They see themselves holding their baby, wearing certain clothes. They see themselves nursing a baby, lying in a certain room with certain colors. So these are people already in a bubble. And there's no need to rupture their bubble in a very aggressive way that tears them apart. So we need to find ways of keeping them happy if there's no need to burst their bubble. So we expect people to smile. People who work in fetal medicine, you should smile at patients. You should be joyful when there's reason to be joyful. Of course, if the baby is dead, you cannot be seen to be laughing. You can't be laughing. We have to sympathize with those who have lost. But if the baby is okay and we are seeing everything, share the same joy with the woman. When she laughs, laugh with her. We don't want people who tell women to say, "Mzukuru, you are disturbing, don't laugh, stop laughing." We have just told the woman that you are carrying a baby girl, and the whole tribe was on her head saying, "Want a baby girl here," and she's overjoyous. And the next thing you are telling her, "Please stop laughing, I want to scan you and I want to finish my work." No, we share the joy with them because we want to improve their experience when they come to us. So communication is very important, how you talk to women. The issue of a doctor who behaves like an emperor to the patient is gone. We are actually slaves to our patients, and we should mind what they want before we mind what we want on them. So this is the modern way of treating women, that women or treating patients, that patients are our kings and queens. We respect them, We ask what is it they want so that we deliver the right package of care to them. To just round up the fetal medicine flow chart, because most people don't understand, why do we book patients? Why do we take so long scanning patients? Because to them, they think a scan should be done in 5 minutes and you are done. So they always wonder, why do these fetal medicine people scan patients for 30 minutes, 1 hour? Why do they do it? So let me explain the flow of patients. Say, how do patients flow when they come to us? First of all, of course, they are received by our midwives or sometimes nurses at Sali. When they arrive, they are received and asked for the reason why they have come to see us. Most of our women are booked. Of course, we have emergencies that walk in that are also looked after. Once that is done, ideally, they are taking their blood pressure to check their blood pressure, make sure their blood pressure is fine. Then history is taken from them as part of risk assessment. We don't scan people we don't know. Because the type of scan, we know obstetricians and other doctors, they just write obstetric scan. To us, it means nothing. Obstetric scan means nothing. It's too generic a term because if I'm to do an anomaly scan and a fetal echocardiography and assess the cervix, I'll need 1 hour. If I'm to do a neurosonography and a fetal echocardiography and anomaly scan, I may need 1 hour, 30 minutes. But how do I know that I need to do a fetal echocardiography? Because there's no history which is detailed in most of the referral sheets. So we have to take our own history so that we do a proper pregnancy assessment. So we take history like no other as part of risk assessment, which may take between 5 to 10 minutes, depending on the person taking history. Then the scan, average time of scanning is around 25 to 30 minutes. If there are multiple defects, this may go for 40 minutes. If they are twins and they are coming for the first time, this may last close to 1 hour, scanning twins for the first time. So then after that, if there is a defect, then we are going to sit with the couple to counsel them and formulate a management plan for the pregnancy. We are not scanners, we are doctors, fetal doctors. So we manage babies we see and the pregnancy we see. So some may say, why are you managing? Because we are doctors. We are fetal doctors. We are not scanners. We don't just scan and say, go to your doctor. Because the best person to explain a fetal pathology is the person who has scanned the baby. Right. So we counsel and formulate a management plan, which some of you probably have seen us writing, or our team has always been writing a management plan based on our knowledge base and our experience of managing these conditions. Then most couples, especially those with severe abnormality, they have to come for a second session of counseling a few days later. Normally they come with the tribe, whereas pregnancy belongs to a tribe in our setting. It doesn't belong to one person or to a couple, especially if termination is to be involved. So we always ask them to come back, then we counsel them again on a second session. So if you look, the flow chart of one patient is close to 1 hour, especially those who come to the specialist clinic. But all patients who come to fetal medicine are actually risk assessed thoroughly. We don't see patients who are not risk assessed. Then to just rush it through and say, how is it organized? Where are we? So the fetal medicine unit is within, it's actually in two units, in one unit and one department. We're within the obstetrics and gynecology unit, but we are also within the Department of Medical Physics and Imaging Science within the University of Zimbabwe structure, and within the obstetrics and gynecology division within the government structure. You know, the working central hospital, there's the government and the university component. The university is restructured a lot, and things are looking different from the government side, which is restructured. So the fetal medicine unit has routine lists which are run by this team of fetal medicine people there. And then we have specialist clinics where we have a dedicated amount of pregnancy, fetal defects, placenta growth disorders, fetal echocardiography, preterm surveillance, and 11 to 13 week scan clinic. So that's the organization. And these are the teams we work with in the fetal medicine unit. We have midwives, we have sonographers, we have obstetricians, and our fetal medicine fellows, and also our junior registrar and so forth, and students. They do come to the fetal medicine to learn. We are pushing to establish ourselves as a training hub, not only for our country, but for Zimbabwe, or for Africa. So we have come up with clinical guidance and case management protocols. So the unit is protocolized. There are protocols. You don't just manage patients the way you want. Protocols are clear, and fetal medicine needs to manage patients the same way, according to a laid down protocol for that specific case, so that we reduce the room for error. Then we are also in the process of coming up with modules under the University of Zimbabwe for all these cadres here. Right, and we are in the process of rounding up a fellowship program. We are waiting for a few nitty-gritties. I think by next year, we should have put everything together, but the program has already been approved by Zimche, and it's ready. But we are waiting for one or two things to be put together. Once we are done, we'll be able to start a fellowship training in fetal medicine with the University of Zimbabwe. We also train all these cadres. I should round up. My time is up a while ago. Then we also do research for clinical care improvement and also for change of policy. So we've established a paperless unit with a patient care database and a dedicated IT and research team. And we have started moving the research protocols. Of course, our processes of approving research is very slow, and we are in that way at the moment. Yeah, so thank you for listening. I'm sorry for exceeding my time. Thank you. I think without wasting much time,